My name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan, and our Learn and Share conference call today is on severe childhood epilepsy syndromes. And we're very pleased to have with us today Dr. Rani Singh, who is a pediatric epileptologist at University of Michigan CS Mott Children's Hospital. So Dr. Singh, can you just introduce yourself and give us a little overview of your experience working at the Comprehensive Epilepsy Program at Mott, and then also talk a little bit about your clinical and research interests?
Sure. Thank you, first of all, Russ, for having me and for everybody calling in, and I hope this will be informative to everybody and also for myself. I am a clinical assistant professor here at U of M, and I'm in the pediatric neurology group in pediatric epilepsy. So I am fairly young in my career. I'm about to complete my second year of formally practicing. And what I do is I work with the pediatric neurologists and other epilepsy doctors here at U of M on treating epilepsy better in our kids of all age. I do primarily clinical work. I have some research interests, mainly at trying to find causes for epilepsy in kids and adults and treating them better. And I also focus here at U of M on evaluation for some kids that may be candidates for surgery to help cure or at least control and improve their epilepsy. So that's what I do.
Okay, great. So the topic is severe childhood epilepsy syndromes. Not everyone is able to get a syndrome diagnosis, so let's talk about what parents should expect in terms of the specificity of their child's diagnosis. So, I mean, on one end of the spectrum, you could have a really nonspecific diagnosis of just seizures or epilepsy. But after that, you might be able to differentiate between partial epilepsy and generalized epilepsy, or you might be able to identify the particular region of the brain that's involved, like left temporal lobe or right frontal lobe. You might also be able to specify whether the epilepsy is idiopathic or cryptogenic or symptomatic. And then in some cases, you can actually be diagnosed with a specific epilepsy syndrome. So can you talk about the factors that influence how specific a child's diagnosis can be, and then what the advantages are of having a more specific diagnosis?
Sure, Russ. So perhaps the biggest thing that helps us as doctors in figuring out what type of seizure or epilepsy someone has is really what happens when the child has a seizure or the clinical history. So for those of you who are parents or family members and have been with your child to the doctor will often ask, tell me as best you can what exactly happened. We categorize seizures broadly as being partial, or a kind of more recent definition of focal, meaning coming from one particular area of the brain, or generalized, meaning that coming from both sides of the brain at the same time. And certain features in what a person might do during a seizure can help us figure out could the seizure broadly fit into either of those categories. That's probably the first thing we try to do to figure out what kind of seizure it is, because that's very important for us to figure out if someone needs to go on medicine, what the right medicine is. There are some medicines that work well for partial or focal seizures, and there are some medicines that work better for generalized epilepsies. After the history, we can use other things to kind of help us figure out what type of seizures or epilepsy someone has. The next thing is the exam. For example, if someone has a child or even adult, we're kind of focusing on kids, has weakness of one side, so what we call a hemiparesis, or one side of the body is weak, perhaps from a stroke or something that happened at some point, that can give us an idea that the seizures are coming from the other side or the right side of the brain, or a partial. So history and physical are very helpful. And then we will often do EEGs and brain imaging. Probably the most helpful imaging is an MRI of the brain. That can also help us categorize things further. With that being said, hello?
Yep, you're still there.
Okay, I just heard a beep. With that being said, just because someone has an EEG, a brainwave test, normal does not mean that they don't have epilepsy, and people can have abnormal suggesting a risk for seizures and not have epilepsy. So even when we do these additional tests, such as EEGs or MRIs, we take into the context the history, and again, going back to really the history can help us diagnose what kind of epilepsy. If a seizure is coming from one area of the brain, a partial seizure, there are different areas where seizures can come from, like Russ alluded to. The temporal part of your brain is where seizures come from frequently, and many adults who develop epilepsy have seizures coming from the temporal lobes. Depending on how the body is affected in the seizure, again, if it's weakness or one side of the body twitching, that can kind of give us an idea. Further delving into, what the cause of the seizure is, and that's the biggest mystery, or what the cause of the epilepsy is. We're learning more and more with all the additional tests that we have. The older kind of categorization of seizures was kind of broadly into about 3 categories, like Russ said: idiopathic, cryptogenic, or symptomatic. And honestly, I probably took a while I was training to figure out what these terms really meant. Right. To be honest, because they were used so broadly. But overall, in the world of epilepsy, as clinical physicians and caretakers of our kids, there is a movement to be as more specific as you can. So idiopathic, I hate that word because I swear it sounds like idiotic to me. Right. Idiopathic refers to a genetic basis of the epilepsy, or for some reason a possible genetic predisposition to having epilepsy. Cryptogenic, in the broad term, and to me, I don't know, that sounds cryptic almost. Yeah, these terms aren't the best. Cryptogenic really means that you think there's a cause, but you kind of look for a cause and you can't find it. And symptomatic means you have an idea of a cause. So going back to the example, if someone had a stroke and then they developed seizures, you would call that a partial epilepsy or a symptomatic partial epilepsy, meaning the seizures are a symptom of the stroke because that area of the brain was injured or scarred, and that's causing the seizures. We do try to, in kids, go further, and there is kind of a movement when kids that go on to have epilepsy to try to categorize them into a better into a type of syndrome. And epilepsy syndromes really can take any of those above mentioned types: idiopathic, cryptogenic, or symptomatic. And I think what's the best help of trying to categorize into a epilepsy syndrome is that it helps us know perhaps what lies in the future. Is this a type of epilepsy that my child will always have? Is it a type of epilepsy that they may outgrow? Is it a type of epilepsy that needs to, the medicine that my child is on work for this epilepsy or not, or do they need to be on another medicine? So I think trying to categorize into an epilepsy syndrome is always the goal that we try to have to do to help our kids and our parents and to have awareness.
Right. So in terms of what parents should expect, I know ideally the more specificity the better, but is it ever acceptable just for a parent to get a diagnosis of epilepsy or seizures and nothing more than that? Or is there a minimum level of specificity that a parent should expect?
Parents should always expect and ask their doctor to be as specific as they can. Honestly, sometimes we don't know what type of seizures or epilepsy a child can have, but we do our best to specify. There's overall a movement with physicians taking care of those of us who take care of kids and adults with epilepsy to try to be as specific and to even document when we tell parents that this is the kind of epilepsy that you have, to say that, how sure are we? With that being said, there are sometimes, and I've had people that come to me and ask, what kind of epilepsy do I have? The doctor I saw before didn't explain, what does this mean? And even with all the information, like I said, with EEGs or MRIs and the history, sometimes, I can't always tell either. Initially, it's harder to try to figure out, but in kids that may go on to have seizures over time, we can sometimes get a better idea of what type of epilepsy someone has.
All right. So there are a lot of rare childhood disorders that include recurrent seizures, and there's also many rare epilepsy syndromes, and obviously we can't cover all of those today, but wanted to talk about some of the ones that are maybe better known or that we run across more often. And one grouping that I figured we could focus on is the epileptic encephalopathies, which includes West syndrome, Lennox Gastaut Syndrome, Landau-Kleffner syndrome, Dravet syndrome, Doose syndromes, and a few others. So can you explain what an epileptic or epileptiform encephalopathy is, and then what some of those syndromes that fall under that category have in common?
Sure. So there has been some recommendations of revising how we classify epilepsies, and people are still trying to get into that practice. And there were suggestions to further classify based on what they call an electroclinical syndrome, meaning kind of like I said earlier, that you put together clinically the history, what kind of seizures, what happens when the child has a seizure, and also electrically, meaning what the EEG shows. So that terminology is still kind of broad and imprecise and not as well defined. So in that group there are what you can call epileptic encephalopathies. And epileptic, if you take that phrase and kind of separate it out, epileptic meaning a tendency to having epilepsies, and encephalopathy is a word that's used more by medical people, meaning a tendency to have be perhaps confused or have someone's baseline or usual level of awareness impaired. When you put that together with epilepsy, really what an epileptic encephalopathy means is that someone has a tendency to have seizures, and these seizures could be affecting the child or the adult's learning and cognition and playing a point. So we try to be, just like with any of our other epilepsies, very aggressive in improving the seizures so we can improve the outcome and help our kids be the best they can be and continue to develop better and learn better and retain information. So that's kind of what an epileptic encephalopathy refers to.
Okay, great. And so let's go into a bit more depth on some of these syndromes. Let's start with West syndrome, which is also often referred to as infantile spasms. Can you provide kind of an overview of this syndrome, its treatment, and its prognosis?
Sure. So West syndrome, all these syndromes are named after pretty much the doctor that discovered, or not discovered, but kind of best defined and classified it, or who was the first to. And West syndrome is named after a Dr. West, and he actually diagnosed West syndrome in his own child. I forgot how long ago, but some time ago. And West syndrome has a definition of 3 parts or 3 characteristics that usually this occurs in infants. And the three characteristics is that they'll have seizures, which are described as infantile spasms. The other, and I'll kind of go more into that. The other part to the puzzle is that the EEG will show an abnormality consistent with infantile spasms, a pattern that's called a hypsarrhythmia. And then the third component is that there can be a halt in the baby's development, or even what we call a regression. West syndrome or infantile spasms tend to happen in infancy, so we're talking usually infants are the kind of medical age definitions are neonates or essentially newborns in up to about a month of life, and infants are up to about 12 months of life. West syndrome tends to affect infants on average kind of in the middle of the first life, between maybe 5, 6, 7, 8, 9 months, but I've seen as young as 2 months. It's probably the youngest that I've seen. And the seizures that they can have are infantile spasms. I don't know if anybody on the line knows somebody or has a family member or your own child that has infantile spasms, but these are specific seizures that tend to occur in clusters, where seizures will happen quickly, often as the baby's waking up and falling asleep. So say around nap time, and the EEG, like I said, will show not necessarily when someone's having a seizure, but the EEG just when the baby's awake or asleep can show an abnormality of what we call hypsarrhythmia. We try to classify, going back to those other definitions of West syndrome, to figure out, is it something that's due to a cause? So going back to symptomatic or something genetic, or is there no cause? So when we find somebody who has that, we're very aggressive, and most neurologists and epilepsy doctors will be very aggressive in trying to find a cause and then figuring out how to treat these seizures, because the concern is the seizures are causing a halt in the development, and we want to minimize that, getting control of the seizures and improving development. There are different treatments in terms of medications, and actually different forms of steroids, with injections, oral steroids, and even sometimes some people will take IV steroids, and some of the seizure medicines that some of you may be familiar with are what we use to treat. Overall, the prognosis varies. The studies and the literature says that more than 50%, I think where I last read was maybe 60%, so 2/3 of kids can go on to develop other types of epilepsy. So even if you work hard and you control the infantile spasms, the other kid, there is a significant chance that the baby can go on to have epilepsy of other kinds of partial epilepsies and such down the road. So we're very aggressive in treating this, and I think most doctors are.
And typically, the sooner you get control of the infantile spasms, the better the prognosis. Is that the case?
Yes. So some places will bring kids, depending on how long things are going, the kids into the hospital to treat them very aggressively, or if not, as an outpatient, treat them very aggressively. But this is something that, to us in the world of epilepsy, is considered an emergency, because just like Russ alluded to, the sooner you treat it and get things under control, the better things will be. There are often situations where kids can be resistant to treatment, and we'll try different medicines, and we'll talk about later other dietary modifications, but it definitely can be sometimes very challenging to treat.
Right. And do when parents come to you, is it often that their kids have been having these for months and they just didn't recognize them, or does that happen fairly often, or do people usually get in fairly promptly when they notice these, or like they only just started happening and they get the child in?
It honestly really varies. I saw one child who had Down syndrome and actually had been having these for 2 or 3 months before they came to clinic. And and sometimes the spasms, there are different forms, so someone might just kind of look like it's a startle, an exaggerated startle, as I think what they can often be mistaken for, or some movements as the baby's falling asleep or waking up, and unfortunately, and actually that child did very well once even things that had been going on for a while. As soon as we are concerned about it, or even if a pediatrician calls me as the doctor on call and say, hey, I'm concerned, it's something that we move for. When it comes to our attention, we are aggressive. We'll get a child in, figure out what's going on, and do the EEG and see what's going on. These days with our fancy phones with videos, I'll often ask even pediatricians to have the parents videotape it, because that can often be helpful for us too. But when it comes to our attention, we do act on these. If there's a concern of infantile spasms, we definitely do act on this very fast.
Great. Do we have any parents on the line who have experience with infantile spasms and would want to share any other challenges or successes in managing it? And if anyone does have any questions or comments, also, if you can just say your name before you speak, that'd be great. Does anyone have experience with that they'd like to share? Okay, we'll move on to the next one then. And again, we'll have more time for questions. So about 20% of children who have infantile spasms go on to develop Lennox Gastaut Syndrome. Can you talk about that syndrome and its treatment and prognosis?
Sure. So again, just like West, Lennox Gastaut Syndrome is named after the people that kind of first recognized it, and a lot of the terms are from the French and the Europeans who kind of in the middle of the last century really recognized seizures and epilepsy. As an epileptic encephalopathy, this has kids with LGS have specific characterizations. So one is, again, going back to the clinical history and the seizure types, is that they'll have more than one seizure type. One is called an atypical absence. So the usual, what we call childhood absence in school-age kids, or the other term is petit mal seizures, or seizures in kids that are otherwise developmentally normal and have kind of brief spacing out episodes, and they can have many per day. That's different. Those are different from the type of what we call atypical absence seizures that kids with Lennox Gastaut, or what we in short terminology call it LGS, have. Those seizures they'll blink out and they'll kind of stare out, and what's kind of atypical about it is that the EEG pattern is different. So if someone has an EEG or brainwave test going on when they have it, it'll show a characteristic pattern. Kids with LGS can have those seizures, and then they can have other seizures where they can sometimes fall, so they call those atonic, almost like you lose tone. And then they can have other types of generalized seizures or even focal seizures. And what really makes the diagnosis is together a history of having different types of seizures, like I mentioned above, and then also the EEG. Like I said, sometimes EEGs can be normal in people who have epilepsy. In this situation, the EEG will show a specific EEG pattern called a slow spike and wave pattern, just in terms of what the seizure epileptiform activity looks like, and that together can give us the diagnosis. Kids with LGS can also have, similar to the babies with Lennox Gastaut syndrome, what we call kind of a slowness in their growth and some cognitive problems. So again, we do try to treat it aggressively, and it can be hard to treat. With most kids need lots of different types of medicines. One of the newer medicine that was finally FDA approved here in the U.S. And a couple of other medicines were approved to treat this particular type of syndrome. That's Banzel or Rufinamide and Onfi, which is the clobazam. So kids with Lennox Gastaut can have usually will have some degree of cognitive impairment, need special help in school, and will have lots of different kind of seizures that can be challenging to treat.
How often do you see positive outcomes? I know it can happen, but how rare is it for you to see kids with minimal developmental disabilities or minimal intellectual disability or cognitive problems and who get their seizures fairly well controlled? Is that possible but unlikely, or is it fairly common? What would you say?
Yeah, it's kind of hard to put a specific, number on that. We try to control all the seizures, but that can always be challenging. In my group of kids that I actually have one or two out of, I don't know, maybe 10 kids with LGS. Again, I don't have as many patients because I'm still just early in my practice. That will have one or two, I'd say, that are well controlled on just one seizure medicine. But that is a rarity. I mean, in most people, it's can be severe, and the seizures can be intractable.
Okay.
What is the difference of a child like that and an adult like that?
Good question. Is it okay if I answer this, Russ?
Yeah.
Okay. So there really isn't much of a difference. We have you can have adults that can also have Lennox Gastaut. Most adults who will have that will have it diagnosed or will have had seizures starting when they were a child, more often in the first decade, and they can go on to have that. And the etiologies can be different. Some people who may have cerebral palsy or CP from something, or one condition that can frequently cause infantile spasms is called Tuberous Sclerosis, which is a genetic condition. People can develop it. It'll start in childhood, but it can go on into adulthood. So there really is no difference. I don't know if I'm answering your question clearly, but.
Well, I see it to be correct because I started my seizures when I was 12, and I have all these problems from I was 12 to my adulthood now, but that's why I'm questioning you of it.
Sure, so it started when you were a child and you still have it, and, like Russ had asked, everybody's different, and the treatments between treating a kid aren't that different. There are certain seizure medicines that are approved more in adults by the FDA than in kids, but we still will often use things for what we call off-label use in kids too, but the treatment is similar. I don't know if you found that different when you were a kid versus how you are as an adult now.
Okay. Thank you.
Mm-hmm.
Yes, Russ, this is Judy Aaron. I thought I said my name, but I think I was muted.
Okay.
What was said about do you have to have West syndrome before you have Lennox Gastaut? That wasn't clear. You said something about 20%?
Yeah, I was saying about 20% of kids who have infantile spasms go on to develop Lennox Gastaut. But you can develop Lennox Gastaut without a history of.
Without it. Okay. I wasn't clear about that.
Hi, my name is Jack. My question is, how easy is LGS to diagnose if your child is already having seizures? My child has seizures. She's now 8. She's been having them for about 3 years. And she's been diagnosed with absent seizures, but as you were saying, sometimes they can be focal, and she's had different types of seizures, and she's currently on 4 different anti-epileptic medications, and the seizures are still not controlled.
Okay. Dr. Singh, does diagnosis, or do you often diagnose children with Lennox Gastaut who maybe had it for a while but never got an accurate diagnosis?
Yeah, that can happen, and I'd say that what kind of can put things together is, number one, sometimes over time things change and things continue to evolve. You might have, she may have had one type of seizure and that was well controlled, or just not alluding just to your daughter, but a child can have one type of seizure that gets under control, but then they go on to develop another type or another type. So, like I said, sometimes, and that can be a frustration frustration as much for us as your doctor as, even for you as a parent and a child, when we can't tell what are the seizures generalized, or are they partial, or are they mixed. But Lennox Gastaut, LGS, comes to more the different types of seizures in the EEG. We'll also see that there's things that we look at on an EEG broadly. One is what we call the background of the waveforms, what your background brain waves look like when you're awake or asleep, and the other is kind of, what is the suggestion of seizures, or if someone has a seizure when they have an EEG, what does it do? So it could be that she has childhood absence, which usually kids, most kids do okay with that, but my colleagues and I do have some kids that have very hard to treat absence, just like your daughter. I think if she hasn't been diagnosed with LGS, not knowing anything about her, what I would think is that her EEG doesn't show those typical changes of a characteristic interaxial, meaning in between seizures pattern, or it doesn't show that her background may be normal.
I see.
Go ahead.
No, I was just following up on that. Now, just so I'm clear on what you're saying, Dr. Singh, is that the only difference between LGS and then having the typical absence seizures is the brainwaves in an EEG. Now, are you saying the brainwaves while she's actually having a seizure in EEG, or the background EEG where you would, so because she's had it overnight and she's had a 3-day EEG where she's admitted in the hospital, so you think with all that they would at least have enough data to diagnose the LGS?
Yes, either or. It doesn't have to be necessarily if someone's having a seizure what the EEG changes would be. It could be even if they're awake. She had the EEG for half an hour in the EEG lab, awake or asleep. So if she's had that many tests and she hasn't been diagnosed with that, then it's probably not that. I can also I've had a lot of parents who have come to me and said, does my child's EEG show LGS? And by the definition of the EEG changes, not, but if they have a mixture of different seizure types, you think less likely. So that's where we're trying to, as doctors, get better at classifying things. And when I tell those parents, no, your EEG doesn't look like LGS, definitely, because they've Googled it or Binged it, read online, they feel relieved. But often, the treatments, even for a child that has hard to control seizures, no matter what kind of epilepsy it is, a lot of the treatments are very similar.
Like you had mentioned, benzo and some of the medications that treat LGS. Do those work on regular seizures also, or those are just specific to LGS?
No, benzos can work for all sorts of different kinds of seizures. They can often have different side effects, making someone kind of sleepy, groggy, drowsy. Kids can be sensitive to benzos that you would think that it would kind of calm you down, but some kids can have the opposite effect, that they take a benzo medicine and they kind of get hyper. But benzos are kind of a broad category of seizure medicines. There are different ones that are used, as rescue medicines, and there are different ones that are used more for daily to try to prevent the medicines.
Which ones are usually used more daily? Because for rescue medication, she's on the clonazepam, which works well. Mm-hmm. But if she's having a sequence seizure where if she has 2 or 3 a day, that will give her a Klonopin and it'll sort of break them off for a few days. But I'm thinking maybe if there's something that's used regular as maintenance, is that an option?
Yeah, there's a new medicine called Onfi is the brand name, or Clobazam is the generic, and I kind of like to think of it as a long-acting form of clonazepam that is more to prevent the seizures. We had actually been using it. A lot of people who take care of kids with difficult to control epilepsies, we were getting it through all the appropriate avenues from Canada, and then it became FDA approved here a year and a half ago, so it's easier to get. That's something you can ask your doctor about to see if that would help her. Some kids do. It is kind of trial and error, but we try to do our best and not be picking a medicine out of our hat. So there are some longer acting benzos to consider.
How is that spelled?
Onfi, ONFI is the brand name, and the generic is Clobazam, Clobazam.
Okay, great. Okay. Thank you.
And let's move on, and again, we can always return to some of these syndromes if people have further questions or comments. But Dravet Syndrome is another syndrome. It's also known as severe myoclonic epilepsy of infancy, and it can pose many of the similar challenges to what we've discussed so far and be very difficult to treat. Can you kind of provide an overview of that syndrome?
Sure. So Dravet Syndrome is also named after a European who kind of first described it in the late 70s, Charlotte Dravet. And it's a medicine, it's a type of epilepsy. The other acronym, I guess I'd say for it is SMEI, which stands for Severe Myoclonic Epilepsy in Infancy. And so these are kids who have Dravet are kids that can sometimes have febrile seizures when they're younger. So the typical kind of febrile seizure that we talk about is kids that have a seizure in between about 5-6 months of age to about 5-6 years of age. And usually those typical childhood febrile seizures are outgrown when you get older. You don't pass that age of 5 or 6 years, then you don't have seizures any longer. But with Dravet's, a large proportion of kids that have Dravet's will have a family history of epilepsy or febrile seizures. They say about 25%, but some have said even half of the kids have had febrile seizures. And they'll go on to have seizures without fever as they get older. One kind is what they call a myoclonic seizure, where your myoclonic just kind of means muscle jerk, so your arms and legs might briefly kind of jerk, and sometimes it can cause you to fall if you're standing. Then they can have generalized seizures that can be tonic, or what would grand mal seizures or tonic-clonic. When it was first reported about 30 years ago, we didn't know much about it, but now we actually know that going back to what the kind of cause of the epilepsy is that this is a genetic epilepsy. It's associated with an abnormality in what we call a sodium channel gene, and that when we get down to the microscopic level of what happens that causes the abnormal electrical signals, it gets down to electrical signals that are transmitted by sodium and potassium and other kind of molecules and channels. And what the cause of Dravet is that there's an abnormality in a sodium channel gene. And that gene can also cause other types of epilepsies, but we do know kind of the etiology. But overall, pretty much, by definition, seizures start in infancy before a child turns 1, and the history that you'll hear is kind of a prolonged seizure, usually triggered by a fever, usually generalized, and that getting a diagnosis of Dravet or ruling it out is really helpful, because there are certain medicines, seizure medicines, that target the sodium channel, and then there are certain medicines that can make these kind of epilepsy worse. And the EEG sometimes can help, sometimes not, meaning an EEG, if you're not having a seizure, a lot of people can have EEGs that are normal. And most of my Dravet patients, if I do a half-hour EEG on them, they are normal. But most kids will have seizures that are hard to control and require multiple medicines, have some cognitive impairment sometimes, and go on to require other things, like we'll talk about a little bit later in the discussion, neurostimulation, like the vagus nerve stimulator. Most of my kids with Dravet have a vagus nerve stimulator to help control their seizures too.
Okay. Do we have any parents who want to share any experiences that they've had with Dravet syndrome, and any successes or challenges that you've encountered?
Hi, this is Rena Price. Hi. Yeah, my daughter Alyssa, she has Dravet, and I found that it started with febrile seizures, but as they get older, it seems like they are more sensitive to, I guess, the known triggers of light sensitivity, overexcitement, and also heat. So those are some of the things that we've had to also encounter. And her seizures have gone from generalized to myoclonics to any, I guess, all in the book there. So that's what we've experienced with it. And we do have the cognitive and some of the physical delays as well.
Mm-hmm. And what's worked and not worked in terms of treatment? Have you found anything to be more or less effective?
Right now, I would say Depakote didn't work for us. The ketogenic diet didn't work for us. Right now, what our cocktail that we have that has been working so far is the Topamax, Onfi, Serpental, and the usofetamine. And we're currently weaning one of those, but we're looking as when we introduce the Serpental with the Onfi, that seems to work the best for us.
Okay. Have you used Vimpat?
No. We tried Vimpat, and it didn't work well with us. She didn't respond well to that one. It actually increased her seizures. We're actually, and I don't know how controversial it is on here, but we're actually looking to try the CBD next. For her, we're trying to stay away now more from the pharmaceuticals. So,
have you heard any reports or successes or research on cannabidiols for people who that's a form of medical marijuana, basically? So
sure, yes. So
that and its effect?
Oh yeah. So in the state of Michigan, medical marijuana has specific elicits specific indications, and epilepsy is one of them. And this is like the mother alluded to, a very controversial topic. There have been studies, but there aren't too many out there. There were some out of Canada that looked at kids with Dravet, and I think there are more recent published studies, and I think that it's been gaining a lot of press that this can help. But I'd say it's the numbers from what I've read. I haven't caught up on it in maybe a couple of months. Are similar to just as what introducing a new medicine in this type of epilepsy that, it's kind of a trial and error. I think, here at U of M, the university, because we're kind of an academic institution, the university kind of has a policy that we don't prescribe it. So that's kind of from my higher ups. The concern about with kids, when I've talked to my colleagues with psychiatry, is that even the form that you can get with the medical marijuana can cause some side effects of the concerns that they have, and that there is kind of more published literature out there about that, is that the younger the kids are who do take medical marijuana, they can have side effects of different kind of psychoses, maybe like seeing things or hearing things. So when I've asked my psychiatrist colleagues what their thoughts are, they have recommended to stay away. So I personally have not prescribed it, and I think I have people that will, for now at least, are telling me, not to. And I think it's and I understand when you are. I've had parents come to me and ask me what I think about it, and I tell them, they can. Unfortunately, I can't do it, or at least not now. But I understand where you're coming from, because you've gone through so many medicines, and you've gone through the diet and everything, and got to give something else a shot.
And does the psychoses and the hallucinations, does that occur even in forms where the THC has been taken out, the psychoactive component?
Yeah, that's what they say.
Okay.
Yeah.
All right. Any other comments or questions about Dravet syndrome? Okay. We'll move on to Landau-Kleffner syndrome, which is one where actually the seizures themselves can be quite manageable, or in some cases may not even occur at all. But can you talk about this syndrome and some of the other challenges that are associated with it?
Sure. So like Russ said, in Landau-Kleffner, there are kind of two components. So one are the seizures, and the seizures can be partial seizures, or they can be grand mal seizures. They start off as being primary, generalized, and continue, or they can be partial and then they generalize. And they're not too often, not like kids with Dravet or some of the other, or Lennox Gastaut, where kids can have very frequent seizures. That's one part, so seizures that aren't too often and not too hard to control. But the other part is what they call an acquired epileptic aphasia, which means that around the time the seizures start, the child's language regresses. So a child may have been able to start talking but then stops talking, meaning the expressive language is impaired, or even receptive, meaning ability to understand and comprehend, is impaired. And in that scenario together, what happens is if you do an overnight EEG on the child, the EEG will have what they call similar patterns. One is called ESES, which stands for Electrographic Status Epilepticus of Sleep, and the other is called CSWS. We have all these acronyms: continuous spike and wave in sleep. And pretty much what that means is that when the child goes to sleep, the EEG becomes very active with epileptiform activity, and it's hard to tell, is that just something, is that a seizure? We don't think they're seizures, but it just means that everything's very active in sleep. And the concern is that when the brain is not firing normally when someone's sleeping, that contributes to the impairment in language. Kids often come to us because in the clinic, of a history of language problems. So I think the recommended thing these days is to kind of do a longer overnight EEG to see if the EEG meets that criteria, and they're specific in terms of what percentage of what time do you see that abnormal electrical activity. it is rare overall. It's something that kind of comes up in our mind, but I'd say out of all my epilepsy patients, I have maybe one or two. And like Russ was saying, the seizures are not too often. So the child that I saw more recently, he's maybe in 2 years had 2 or 3, what I think are convulsive seizures. But the language regression is something that we are very serious about. So the different treatments are, there are different treatments for it. Some will, one is steroids, like an oral prednisone. The other, certain anti-epileptic medications might be more helpful than others, like Depakote or valproic acid. And the other treatment is Valium or a typical other type of benzodiazepine, or the clobazam or Onfi that's come up more recently as something to take at night to help improve the language. So we look to get improvement in language and get the child talking again and doing better, and also to control seizures.
Could you please repeat the last medication that you said was most recent?
The child I have who's done my most recent child I took care of, I met them about a year ago, and he's about 5 or 6 now. I think he's 6, and I suggested prednisone, and his parents didn't want to try that. I suggested some other. He had come already on other medicine, and what he improved the most with was another medicine that's been coming up a lot in our discussion is clobazam, which is a long-acting benzodiazepine, CLBO, Cloba, I have to think about that, CLOBAZAM, or the brand. It's only available here in the U.S. now as a brand name, Onfi, ONFI, F as in flag, Frank, yeah.
Okay, any other questions about, comments about Landau-Kleffner syndrome?
Hi, I do have a question. My name is Carol. Now, they say that the seizures, my son has LKS, and he has major seizures with it.
Mm-hmm.
I mean, he crashed about a year and a half ago. I mean, he crashed so bad we almost lost him because the seizures had gotten really, really, really bad. And that's what they're telling me that he has is the LKI. Yeah.
Sure. No, I think there's, with all these epileptic encephalopathies, there's a very wide spectrum. So a lot of kids with LKS won't have as frequent seizures, but your son is definitely, I can understand that your son definitely, has it. Does he have the language problems too? When his seizures started?
No, actually, he didn't start talking until he was about 3 years old. So he had language problems right
from the beginning. Yeah.
I had kept telling the doctor that there's something not right. They kept telling me, oh, no, your child is fine. Couldn't find out when he finally had a major grand mal seizure. It's like, oh, yeah, well, maybe there is a problem. So I'm thinking all along that he was having seizures and stuff, but they kept telling me, no, he wasn't. And like I said, he's moderately cognitively impaired now. So he's delayed in all areas.
Mm-hmm.
And nobody can tell me, what can I expect? What can, will he outgrow the LKS? Is it something that's always going to, is it always going to be a problem because he starts to gain, goes into a grand mal, loses everything, we have to start from scratch again, I mean, he's on the Onfi now, which honestly has done wonders for him. So, but he is, moderately cognitively impaired and not gaining much in those areas.
So in terms of prognosis, Dr. Singh, with LKS, do the cognitive and language problems tend to persist into adulthood?
They definitely can. It sounds like with your son that he has something that just a lot of these other epileptic encephalopathies can have, is that he has a baseline problem with his baseline level of cognitive impairment, and then when he has a seizure, you make several steps forward and then you make steps backward. Am I correct that he regresses after he has a seizure?
Yeah, and sometimes he can start to regress before the onset of a series of seizures.
Mhm. Yeah. Has he ever been on steroids?
He gets extremely violent.
Yeah.
So he could not stay on them.
Yeah. Yeah. And steroids, when we use them in these situations, most people will use them transiently to see, but that's definitely a side effect of the steroids, because they're at decent doses, is that they can cause definitely cause the behavioral side effects. And he's been on. You said Onfi has helped.
Yes, Onfi has helped control the seizures. Since he's been on it, he's only had a few, and they haven't been major ones like he was having.
Yeah, and it's hard to tell. It's a very frustrating thing as a parent, and even definitely more for you as a parent, because you're living with this with your child, and you're seeing your child go through this of this kind of fear of the unknown. But I guess my advice would be, to encourage his doctors to continue to, be as aggressive as they can, look at other therapies. I think Russ and I will talk more about, the special diets. Have you looked into a special diet for him?
No, because they were thinking he might have had a mitochondrial disorder. They've pretty much ruled that out now.
Okay.
But, I was told that the LKS said he would outgrow it.
Yeah.
Is that a true statement or not a true statement?
It's hard for me to say, because I'd have to look into more of his history. If he's as with LKS, the more typical thing is that kids do get better. So the question is there something else going on? Is he more of a And when it comes to these epilepsies, things aren't, unfortunately, there's not a lot of black and white. There's also a lot of gray. So is it that he has more of a form of a Lennox Gastaut type epilepsy than a Landau-Kleffner? I think it's kind of hard for me to tell. I'm sorry.
Right. So yeah, I think that's an important point, is that these syndromes aren't necessarily always clear-cut, and there could be some overlap, or I've heard a lot of people say they have an LGS type or similar to LGS, but not really LGS, and a lot of people say that they have something that's on the border of one of these other syndromes, but not quite. So I think it's important to realize that not everything fits neatly into those categories. So. And of course, within each, from one individual to the next, the prognosis can vary significantly. So, let's just move on to one last syndrome that I wanted to mention just briefly is Doose Syndrome, also known as Myoclonic astatic seizures, and that can sometimes be categorized as an epileptic encephalopathy, usually with a poor prognosis, but in some cases it may not fall under that category and may tend to have a better prognosis. Can you talk a little bit about that syndrome, just quickly or fairly briefly? Sure.
So Doose Syndrome is also known as MAE, which stands for Myoclonic Astatic Epilepsy, and this is considered to be an idiopathic, or like I was saying earlier during the discussion, genetics generalized epilepsy. And kids can have absence seizures, they can have grand mal seizures, and then they can have myoclonic seizures, muscle jerk seizures where they fall. I don't know if who's out there in the audience, but a lot of the similar seizures that kids have with Doose sound kind of similar. If I didn't know epilepsy and I was hearing this, similar to kind of the Lennox Gastaut, but the EEG is different in Doose compared to Lennox Gastaut. The typical age of onset for Doose are kind of the young school-age children, so most of my kids who start with it are maybe 3, 4, 5, 6 years of age. And if you look at the numbers, most kids do better. So the prognosis for Doose in terms of potentially outgrowing the epilepsy is better than the Lennox Gastaut. They say about maybe 60% of kids will outgrow Doose. But I feel like, I don't know if it's because I work in a big referral center, but a lot of my kids with Doose are harder to control. And this goes back to the mother who I was speaking before, is that there is a lot of gray. I have a lot of kids that I feel like they have Doose, but maybe they're just I get the ones that are very hard to control, and we put them on lots of medicines or even special diets. So there are two things that I want to say about Doose that I don't know if there's anybody who knows anybody or any parents that are on the phone about Doose, is that going back to the fact that we're learning more about genetic bases of epilepsies, is that the same abnormal sodium channel in Dravet Syndrome has also been seen in Doose Syndrome. And there's also another entity, a type of genetic condition that can cause Doose Syndrome. It's called GLUT1, GLUT1 deficiency. And what that is a problem with the ability to take, at the simplest terms, glucose, which is kind of our main energy source in our body, an impairment of glucose to go into the brain. Studies have come out that have said that looked for this type of GLUT1 problem in Doose, and between 5 to 10% of the kids with Doose have been found to have that. And the big important thing for thinking about that is that the mainstay of treatment for GLUT1 is the ketogenic diet. So those are kind of the two things I want to say about Doose. That we're learning more about some genetic associations with Doose syndrome.
Okay. Any questions or comments on Doose syndrome? I wanted to, because we do have several school nurses on the line, I wanted to cover one specific topic, which was the idea of status epilepticus. And several of the syndromes that we've talked about carry an increased risk for status epilepticus, and that's prolonged seizure activity. Can you go over some of the current and emerging management options for parents and school staff in terms of managing status epilepticus? And then also, in terms of non-convulsive status epilepticus, can you talk about how to recognize that and respond to that?
Sure. So, the kind of broad definition, like you said, Russ, of status epilepticus is prolonged seizure activity. There's a lot of debate as, how long is too long? How long do we know how well or how good are we at observers or bystanders and being able to tell how long a seizure has been going on for? Some people say that the kind of old school definition of status epilepticus was seizure activity for more than 30 minutes. Now they've kind of decreased it to 20 minutes, or even, some people, a lot of the studies that have looked at these rescue medications that are available have even looked at for seizure activity for more than 5 minutes. It can be a seizure that is a convulsive seizure. It could be a seizure where you're just a child or anyone is staring. What we do know is that the vast majority of seizures are self-limited. More than 90% of seizures will stop on their own after 5 minutes. The big, $1 million question is, do seizures cause brain damage? And that's where a lot of the epilepsy research is on looking at animals with epilepsy and what happens, at the microscopic level. Now, in terms of rescue medicines, I think it depends on the type of seizures. Some kids have been prescribed the rectal medicine, the rectal diazepam. Some kids might have a tendency to have a cluster of seizures. For example, I have talking about Doose, a little girl who I think has Doose, but I think it's in that gray area where it might be another type of challenging myoclonic epilepsy, and she has tons of myoclonic seizures a day, and then if she has too many, she'll to get the rescue medicine of the clonazepam, which is the oral, comes in a tablet or even a melt-in-your-mouth kind of wafer that a lot of people like. More recently, what's been studied are intranasal forms of rescue medicines, and all these rescue medicines are the benzos. One is intranasal midazolam, which is becoming more readily available here. I have some patients that, the kids that are older who don't like the idea of something being, stuck up their butt, for lack of a better phrase. Once the kids get older and kind of are more aware and, into adolescence, the intranasal midazolam, the other word for it is Versed, is an option. There have been studies that show that that's as effective as the rectal medicine, as a rescue medicine. The key thing is that you have trying to find a pharmacy that'll make it. There's a compounding pharmacy that we have that I send my patients to in the Ann Arbor area, but the annoying thing is that the half-life, the shelf life, because it's compounded, they make it from scratch and mixes that, it only lasts a month. So that's a real pain, because the rectal medicines, I don't know how many of you are, as parents or nurses, have seen. The rectal diazepam has a life of about 2 years before it expires. One medicine that's not yet FDA approved, and I'm not sure if or when we'll get it, is that there's also a buccal form, meaning in your mouth, you put it in your cheek and it gets absorbed through your cheek, of the same medicine that's available through the nose spray, the intranasal midazolam. I think that's having trouble getting through the FDA, so it's going to be some time. But I'd say the other kind of new thing that's out there on the horizon, aside from the clonazepam, melt in your mouth, or the rectal diazepam, is the intranasal one. Now, when it comes to the non-convulsive status epilepticus, that's something that can be really hard to recognize. And what that means is that someone's having a seizure, but essentially it's not a full-blown convulsive seizure. So someone can be just staring. Sometimes they'll do things that, little subtle things that you might be able to recognize if it's a seizure, like kind of some non-specific mouth movements, what we call automatisms, like chewing or, staring but not seeming with you. If you try to get them to respond, they might look at you but not completely follow you or be able to follow commands. That's something that's kind of harder to tell, even, for me as the epilepsy doctor, telling if someone's having a non-convulsive seizure. That's definitely something that we do get concerned about, but and we want to know about and treat.
Speaking of that, Dr. Singh, the non-convulsive seizures, that's pretty much the majority of my daughter's seizures. And, how long do you go with that before you want to take some type of medical action, to protect yourself and your child? Like, she has, her seizures are in control, so she can have, upwards of 3 a day. Sometimes she will have nothing for 2 months, then she'll have 3 a day. But now with status epilepticus, if I'm understanding correctly, they don't have to be continuous. They can just be a seizure, then she doesn't have it, then she has a seizure, then doesn't, then has a seizure. How long do you go with that? And like I said, they are non-convulsive, so it's mostly just the staring. Sometimes she'll have drooling, but she'll have the mouth, chewing, type stuff like that. How long do you watch for something like that?
Well, no. So the other definition of status epilepticus, kind of one, in the most general terms, is one definition is a prolonged seizure, and the other definition is frequent seizures back to back and not returning back to normal in between. So when she has the seizures, it sounds like she has a tendency to cluster, maybe having 2 or 3 seizures a day. How far apart are they spaced out?
Sometimes they've been as soon as within a half hour. Sometimes, they'll be longer. Yeah. So they haven't gotten to that point where, I was really concerned about status epilepticus because they were spaced out enough where she had come back to normal or, she'd rested. Normally our sign is once we get a verbal response from her, we'll say, are you okay? Are you better now? Even if it's just a yes, we know she understood what we said and she responded, voluntarily. So we think she's okay. And then, she may go and rest and sleep because she's tired from the seizure. And she'll get up and 10 minutes later she'll have another one.
Yeah. And it sounds like that's for what you use, the Clonopin?
Yes, that's normally what we do. When she does that, we'll give her the Clonopin wafer.
Yeah. It sounds like that's if she has a tendency to do that, and I have a lot of kids that if they tend to have a tendency to have a cluster of, a certain number of seizures in a certain time period, and again, everybody's different, so like Russ and I have been saying there's no black and white, there's a lot of gray out there, and you have to really individualize it to the particular, child, particular patient, the particular situation, the type of epilepsy to figure when is it time to intervene or do something. But it sounds like, I from what you've told me about your daughter, it sounds like, the doctors are taking good care of her, and, I kind of agree with how you guys are doing things.
Okay.
Does anyone else who I'm looking for people who haven't asked a question already, or is anyone else who hasn't had a chance to ask a question, have a question that they'd like to ask?
Hi, I do. I'm a school nurse. Mm-hmm. And I would like to know when you're talking about the staring seizures, not following the commands, at what age would we see that? And if we haven't seen it, like, say, prior to 2nd grade, 3rd grade, 4th grade, would that be something that would happen in the middle school grades or high school grades with a sudden onset of that?
So are you referring to a child of any age who has a diagnosis of epilepsy or no known diagnosis? No known diagnosis.
And then all of a sudden we're seeing a change.
Okay.
And not a sports head injury or anything else attached.
Sure. So broadly coming, and speaking in terms of staring seizures, on the broad definition, there are kind of 2 kinds if they are seizures. One are what we call absent seizures, where someone will space out very briefly, although when you're sitting there observing, it can seem like forever. Usually those are maybe 10, 20. I have seen some as long as maybe a minute at a time. And when they come back to, it's like they never left. They don't remember, they don't know that they had checked out. The other kind, if it is a seizure, are the complex partial seizures that can tend to usually last longer, maybe a couple of minutes, where someone might stare and they return to and they're kind of confused, like, hey, what happened? And honestly, these seizures can happen at any time, any age. There's no, magic cutoff. The other question, though, is that there are situations where kids or adults can have episodes of staring and they not be seizures, and that's where things can get tricky. If you are there and you see them staring, a couple of things you could do is first, call out their name, see if they respond. If they don't respond and this is what we'll often tell parents to do when kids come in with staring episodes, and we're trying to figure out is it something that's a seizure or not. You can call their name out. If they don't respond, then you can kind of nudge them, poke them. And then what we'll do is give a memory item, just kind of like a 2-word phrase, like what most of us do in our practice, or we'll say is a color and an animal, like purple pig, and say it, and then when the kid comes back to say, hey, I shouted the name of an animal. Do you remember what it was? Try not to prompt them and stuff and see if they remember. That can kind of point and suggest, though not clear cut, that, maybe someone was having a seizure, but to kind of really answer your question, things can happen at all times, and sometimes it's hard to tell if it's a true seizure due to abnormal brain wave activity or if it's some type of behavioral episode.
Okay, can I also follow that up? In general, here at our school, and I'm a district nurse, but I'm the only one actually in the county. If we don't have a doctor that signs orders basically for an emergency plan, our emergency plan would be anything greater than 5 minutes. We don't call 911. Until then, we're making them safe and all of those kinds of things. All staff's educated. But I guess my question is that knowing like I don't have a diastat or anything else like that, we do allow them to rest. Parents are notified. Is that a good enough plan, or should we have something else in place in the school?
So I think it depends on. You're talking about kids that have a diagnosis of epilepsy?
Yes, ma'am.
Okay, and they have a seizure.
Correct.
I think if it's the first time, that's okay. The question is if this tends to be with one child to be a recurrent theme, then I would encourage the parent, to talk with the doctor. What we do here, and, I know we're not 100%, I don't think any place is that it often comes in the beginning of the school year. August, September is when we get the parents calling that school needs school forms, and we'll fill out the action plan. Because we want you, number one, we want our kids to be safe and okay, and I think you need to do, as a school nurse and, a school administrator, you need to do whatever you need to do. If it happens once, then, I would have suggested the child and the parent say, hey, why don't you talk to your doctor and let them know what happened and see if we need to do something else. Or have, a more kind of, do medicines need to be adjusted, or does there need to be a more defined, kind of plan of action?
Okay.
Any
Hi.
questions? Go ahead.
I got a quick question on a medication, Depakote. I know they usually say it's associated with, being tired and all that kind of stuff. At what point, or like how tired would the child have to be before we could call it, a side effect of the Depakote, or how high up should we go?
So when the goal with any medicine is that we try to, before we say somebody has a child or anybody has failed a medicine, is that we try to say, was it informative, meaning was in the situation you're giving, was the Depakote the right medicine for that type of epilepsy? And honestly, Depakote's a great medicine for most type of epilepsy, so the question for that would probably be yes. Yes. And is it stopped because of potential side effects? Everybody's different. Most of all the way we pick the right dose for the child really depends on the child's age and size, so we know what kind of an upper limit of normal is. Sometimes some medicines, lab levels are helpful, and Depakote is one of them that checking a lab can be helpful. I'll sometimes check it if I feel like I'm pushing it up too much. And the other thing is to make sure, is it the Depakote or is it something else that's caused?
Right, so that's what I'm saying. Like, she's not at the upper level yet, but I do feel like in the mornings it's hard to get her up. But is that normal? Is that just normal behavior for her age? Or is it actually the Depakote? How do we decide?
Yeah, is she a teenager?
She's 8, so no.
No.
But she always was, like, hard to wake up in the morning, but now I feel like she's a little bit harder.
Yeah. So, and then before saying, what I would encourage you to do, especially if you've seen an improvement in the seizures, is before, marking it off your list, even trying to make adjustments. For example, adjusting the morning dose, adjusting the nighttime dose, going high, going low. Not all people need to have the medicine, the morning and the evening dose to be the exact same. tweaking, I would encourage you, if you think it's the sleep before, especially, now if it hasn't helped at all with the seizures, then, that's a different case.
It is kind of helping. It's the only thing that helps so far. So,
then
we want to go, the doctor actually wants to go up on it, to kind of control the breakthroughs. But now I'm kind of feeling like maybe in the morning she's just so tired she can't get up.
And then, when you get her, another question is, does she get up, and once you get her up, is she able to go, or if she gets to school and she's still super groggy?
She's better. She's better once I get her up, but she's not, perfect yet.
Yeah.
And then the 8 o'clock, go ahead.
I'm sorry, go ahead.
So I'm just wondering about the 8 we give her a dose at 8 p.m., would that still be affecting her in the morning?
It could be, yeah. Especially if she hasn't had the dose, if she hasn't had her morning dose yet, then you can't blame it on the morning dose. And usually the evening dose kind of helps protect through the night into the morning. Mm-hmm. So that's probably it. You could see about timing it earlier, giving it at maybe 6 p.m. or even cutting that nighttime dose down a little bit then. Mm-hmm. So that's the biggest thing, is that sometimes medications are limited, even though they might work well for the seizures and control the seizures as the potential side effects.
Mm-hmm. Yes, I tell you, with that medicine, it controlled my seizures completely. It was the best medicine I was on, but I was very tired from it, and I gained 100 pounds from it. So I never take that medicine again. Never. I do not want all that weight back.
With that being said, some people with Depakote, sometimes it helps to take a carnitine as a supplement with the Depakote. It can kind of help boost your energy a little. So that's something you could talk to about the doctor before, necessarily kind of marking it off the list and moving on to the next one, especially if you are seeing some benefit.
You said Depakote with clonidine?
Carnitine.
Carnitine. Okay. Really? That's over the counter, am I correct?
Yeah, it is, but I would talk to your doctor about, thinking, what
dose to use.
And if it's seen.
Okay, that's a good point. Okay, right. Thank you.
Dr. Singh, I want to give you the opportunity to leave if you have to. But if anyone has any other questions, I can. Cindy and I are both on the line, so we can answer any or try to answer any questions if there are any remaining ones. Are there any other questions that people had? Okay. Well, thank you, Dr. Singh, for all your great information and for your time and for staying on a little extra. We appreciate that. And I hope this was helpful for anyone. I will stay on the line for a little bit longer if anyone else has any last questions that they wanted to ask.
Sure. I don't know how many people are still on their line, and I wanted to tell you, Russ, and other folks about, I don't know how much people know that for people who have Dravet and other genetic channelopathies, there's actually a registry that's through U of M and Miami Children's Hospital, and we're really encouraging people who have kids with these diagnoses or adults to register just to help us learn more. It's through the Dravet Syndrome Foundation. But, Russ, do you know about that?
No, I don't. That's great to know.
Okay. So it's called the International Ion Channel Registry. And the website is, I'll forward you the link to an email. It's www.ice-epilepsy.org. And it's an international registry where we're just trying to, do whatever we can to take the best care of our kids with these.
Okay.
And it's also, there's a lot of patient information.
Are there other syndromes that would fall under that?
It's Dravet, GEFT+, SMEB, so mainly the sodium channel gene mutations.
Okay. Thanks for letting us know. Yeah, I know there's the EPGP study as well, but that's closed now. So this is another one, though, that people who have this can contribute to our understanding of it by registering. So that's great. Okay, well, thank you very much again for your time, and thanks everyone for participating. I hope this was helpful. The next one we have in July is on July 3rd from noon to 1:30, and that's on medications for epilepsy.